everyone. And I think Chennai Pancreas Club was started almost, I think, 5 years ago. Of late, we are not very often meeting, and I think this is the first meeting of this year. And when we started initially, I myself and Patta was very keen on to have this kind of, not a very formal meeting, more of informal discussion and interaction with the audience, and it went on successfully. Subsequently, Parama also took an initiative and started. Now Parama is having another huge responsibility. So I request from this year onwards, Sheshadri will have as a convener and to conduct next year, because whenever a fresh young mind comes, they will bring new ideas and make the meeting more interesting. I request Sheshadri to start this month's meeting.
Thank you, sir. That was a compliment. Young mind in சொன்னதுக்கு. Anyway, we'll start off. I think we are seeing a lot of known faces, few known faces, a lot of new faces. I think we should start off with introduction. So we can start. We'll start from here. You can introduce yourself. And before we start off with the proceedings, I think agenda. I think Dr. Radhakrishna must be having the agenda. I don't know about the agenda. So we have a discussion of a case of ERCP pancreatitis, and we can take it from there. Yeah, as a small lecture. And of course, the basic idea behind this whole meeting is it should be interactive. And you can ask questions anytime, you can discuss anytime, put out your points anytime. Okay. So let's hope we have a nice meeting. We'll start off with introductions.
Paramanayagam, consultant medical gastroenterologist at Apollo Hospitals, Chennai.
I am Dr.Ubal, consultant medical gastroenterologist at Apollo Hospitals.
Prem Kumar from KMC. Professor of Gastroenterology.
Dr. Hariharan, Apollo Hospitals.
Dr. Nirmala, pediatric gastroenterologist, ICH.
Dr. Joy Mon, assistant professor, Madras Medical College.
I'm Dr. Raghunathan from MMS.
Hi, I'm Dr. Ashrita. Actually, I'm doing DM in pediatric hepatology from Institute of Liver and Biliary Sciences, Delhi. I had come to ICH for a month, so under Dr. Nirmala ma'am, so I'm here with her.
I'm Dr. Sindhuja, doing my DM pediatric gastro at ICH first year.
I'm Dr. Deepa, doing first year pediatric gastroenterology, DM resident.
Hello, I am Dr. Bershik, second year gastro resident in Chennai Medical College.
Hello everyone, I'm Dr. Avnish. I'm doing DM gastroenterology from Chettinad Hospital.
Hello everyone, I'm Dr. Mithun, postgraduate in first year medical gastro, Chettinad Medical College.
Good evening everyone, I am Dr. Aditya, doing MRCS and service guidance from SIMS. I've been posted here for 2 months, so that's how I'm here. Thank you.
Good evening, I'm Dr. Hari, doing my MRCS at SIMS. I'm currently posted on gastroenterology under Dr. Patta sir.
Good evening everyone. I'm Sunita, Physician Associate in Surgical Gastroenterology under Dr. Patta sir in SIMS Hospital.
Good evening everyone. I'm Priyadarshini Natarajan, Physician Associate at SIMS Hospital in Surgical Gastroenterology team.
Good evening everyone. I'm Humaira, Physician Associate at SIMS Hospital under Dr. Patta Radhakrishnan sir.
Good evening everybody. I'm Swarna Dhanashekhar. I'm a Physician Associate. I work with Dr. Radhakrishna Patta.
Good evening everyone. Myself Dr. Udayam, a laparoscopic surgeon working at Dr. Patta sir.
I'm Dr. Patta Radhakrishna, GI surgeon, SIMS, Vadaparani.
I am Dr. Magnus. I am a surgical gastroenterologist. I am part of Dr. Patta's team in SIMS.
Actually, for these pancreatic Chennai Pancreas Club meetings, we pick up a topic and then we try to have a few case presentations and sort of open discussion. And this time we took up a case of ERCP-induced pancreatitis. It's quite a lengthy case, so my associate Swarna will be present in the case, and as is the convention, at every juncture we stop and we deliberate and discuss and see what is, how to proceed further, what is right, what is wrong, how can we be better. So Swarna, please. That will be followed by a lecture on, a small lecture on ERCP pancreatitis by Dr. Magnus, my associate.
Good evening, ladies and gentlemen. I'm here to present a case of ERCP-induced severe acute pancreatitis. A 61-year-old female had complaints of abdomen discomfort and intermittent non-bilious vomiting since about 4 years. She also had frequent episodic dyspepsia, anorexia, bloated abdomen since 6 months. On further probing, she had history of bilateral lower limb itching since 2 months. She did not have any other conventional symptoms or features of jaundice, bowel or bladder disturbances. She had history of spondylitis and lower backache since the past 12 years, for which she was undergoing physiotherapy. She had history of pupil sterilization done 35 years ago and bilateral cataract surgery done in 2017. She was initially evaluated elsewhere. The ultrasound abdomen showed a well-distended gallbladder with multiple mobile calculi. The liver appeared normal in density. There were no features of cholecystitis.
Okay, we'll stop here, then we'll start with Shesh. Should you comment as to, I mean, if you want to go back to symptomatology and the ultrasound findings, what would be a line of thinking or line of management? And I just want everyone to just pitch in and to comment, and but you should have a microphone in that corner.
Go one slide backwards.
This story happened elsewhere.
Yeah, she's been, this 61-year-old lady, she's been having typical abdomen pain. You don't know whether it's a right side or it's quite sometimes she's been having this abdomen pain. Characterized as abdomen discomfort, not specifically as right hypochondrial pain or whatever it is. And she's been found to have some gallstones. But I mean, before proceeding, we will have to know whether clinically she had any tenderness in the right hypochondrium, and then we'll have to proceed, get some liver function tests, what it is, how is it, and then we'll proceed accordingly.
I'm not very convinced that she has a biliary symptom for the pain.
Right.
It was an incidental finding when probably she got evaluated for some dyspeptic symptoms. That is what I can make out. I don't know whether the stones are the cause for her symptoms.
I mean, if this is all the history that's given, because we don't know what exactly happened at the place where she was treated. But with this situation, what next would you do?
At least I'll get some basic blood work done, and probably an endoscopy also.
That's a blood work. Yeah.
Also an endoscopy because I have some dyspeptic symptoms. So I'm not too convinced that. That's right.
Dyspepsia. But these are the liver function tests.
Normal, no?
Right. Next.
She had undergone an MRI abdomen.
Now, but here, I mean, we were wondering whether MRI is indicated. Whether MRI is indicated. What does MRI show?
It showed a well-distended gallbladder with multiple T2 hypointense laminated calculi at the fundus in the body, largest measuring about 9 cross 8 mm. There was no feature suggestive of cholecystitis. The CBD was prominent, which was measuring approximately 8 mm, and showed a small linear oval-shaped 2 cross 6 mm T2 hypointense shadow at the lower end of the CBD, which is suggestive of lower CBD calculus. There was no significant IHBR dilatation or pancreatic duct dilatation.
So, Patta, why MRC, if you know?
I don't know.
Oh, it is done.
It's no, because this is how the story went. So we just want to look into each aspect of it as to whether what is done. I mean, whatever information we have. Hari? It doesn't need a microphone. Okay.
They also agree. I don't know why they did an MRI. That's a question. But now, knowing that we know the topic you're going to discuss, so MRI it's going to be a problem. But why they have done, from where thing is that why do it? I don't know.
Okay, any comment from your side?
These are the representative images of the MRI abdomen. She underwent ERCP. Side viewing scopy showed a large periampullary diverticulum, as shown in the picture. The ampulla was flat, tiny, and featureless. They did try cannulation. They attempted, but it failed.
Ubal, your comment?
So as everybody said, not very convinced about the CBD stone. So ideally will be a UES before ERCP attempted, because whenever elderly like this kind of lady presenting, that periampular diverticulum is very often a finding, and so cannulation is going to be difficult in this kind of cases. Even expert learns there is a failure rate of almost 20% if there is a periampular diverticulum. So being the LFT is normal and no symptoms of classical biliary colic, and before attempting ERCP, because any interventional procedure, you should have a strong indication for a procedure itself. So I think US mandatory in this case.
With this LFT and with this MRCP, would you still attempt ERCP or would you wait?
LFT is being normal. Even the MRCP is not very convincing for a stone disease, and I would have advised an endoscopic ultrasound. If the LFT is abnormal, definitely I would go ahead with the ERCPs. Being LFT normal plus no symptoms of jaundice or biliary obstruction, cholangitis.
Yeah, Ari, you have a comment to make, madam?
No comments.
See, the very point we are discussing today is that an invasive procedure like ERCP is not without its problems, and it has serious outcomes sometimes. So here comes a lady, 61, not much of a symptoms. Like the way that she describes is more like a dyspepsia. In such cases, there is no urgency to go and check for or remove the CBD stone. You can take your time and do it. There is no urgency. But like, as Ubal says, is that, he's an expert. He keeps doing left and right. But at the same time, if that comment comes from Ubal that he will hold back, I can guess and understand that how risky sometimes it is. And people should really, truly appreciate that the post, it is easy to go and meddle with anything. But once you have a complication, and when you can't explain yourself, that is when the problem will start.
My question would be, if there is no periveterian diverticulum, would you go?
No, irrespective, man. Right from the beginning, we were never thinking of anything towards a biliary treatment.
For our knowledge, if there is a diverticulum of that nature, what precautions would you take, or what are your technical aspects? How would you?
So basically, identifying papilla in this kind of periampular diverticulum will be challenging, because it can be either in the edge of the diverticulum or in the base. So what we usually do is we use smaller forceps, biliary forceps, where we can pull one of the limbs of the diverticulum and see the papilla. So that sometimes give an idea. Some people will even use a clips, put that there so they can drag and bring the papilla, because sometimes what will happen is that papilla will be seeing inwards, that is inside the diverticulum. You cannot see by the side viewing scope. You have to pull the edge of the diverticulum, and so you need to have extra instruments. Basically, you need an expertise, basically. So
The MRCP usually, does it show the diverticulum? Do we get an idea on MRCP?
No, MRCP sometimes it can mistaken as because this kind of diverticular they can mistaken as a stone disease.
Diverticular mistaken as stone.
Yes.
How?
Yeah, in the diverticulum sometimes superimposed. It can superimposed as void inside.
Okay.
That could have been seen as a filling defect in the.
Okay. Any other technical point in these patients of
Brahma,
There's one advantage of EUS is that you can insufflate with a little bit of water. So the water usually will fill up. Whatever air is there inside the diverticulum will be driven off. You can fill it up with water so that now we know what the structure is. So if it gets filled up, we are not looking at an intra CBD problem. You are looking at something in the duodenal lumen. So that gives us a clue as to what is happening, and then we can trace the bile duct much better with the EUS.
But any other comment? Anyone?
I didn't get you, Pirama.
There is a doubt whether there's a stone or, because sometimes you will feel some, particularly in EUS, we find air and bile stones to be a little hyperechoic. So when it is very close to the ampulla, it always is it's a doubt whether there's a stone or sometimes it could be a diverticulum. And we are not very convinced. We fill the duodenum, we stop the air, we fill the duodenal lumen with water. So water usually will get into the diverticulum, and you can see that the character changes from air to a completely water. So now we know that you are looking at a diverticulum rather than an intraductal calculi. Correct. So the air, fill it up so that it will all become dark.
As far as the diverticulum is concerned, other problems we can have is sphincterotomy cannot be wide.
Okay.
You'll have to be very careful with the sphincterotomy. We can easily damage the wall. And then when we bring out the stone, since there is no support on the wall, sometimes it tends to go into the diverticulum. We'll have difficulty in extracting the stone sometimes. So these are two other things which we have with it.
The beauty is that, when you talk about difficulty with diverticulum, there can be diverticulum like outside on both sides. To clear this thing. Such cases, doing the sphincterotomy, you have to go through, but to cannulate will be key. So there are advantages and disadvantages. First of all, there can be diagnostic problems. When there are two diverticulum on either side, with the ampulla right in the center, it will just be a very easy cannulation for a baby's cannulation. It will just go through. But if it is on one side, imagine the diverticulum is like this. The ampulla, usually we expect it at 7 o'clock. If there is a diverticulum you are facing on, the first thing is that if I can't see something, I will always face towards that 7 o'clock position, which is where I normally expect how the diverticulum forms, and that is where I want to go and check. If it is not there, there are people who tend to do a submucosal injection just to lift the ampulla sometimes. And the worst thing is that if the ampulla is well within the wall, the floor of the diverticulum, you are more or less finished. Okay, so that is when the problems are. And Paul pointed out very clearly that cannulation of an ampulla with a diverticulum, you really need your hands plus your technician plus your nurse. Sometimes you have to use a biopsy forceps. The thing is that that there is only one channel. We'll have to put the biopsy forceps through, and we have to put our ultratope through. When we have both, the other one trying to pull it up, it is just a simple coordination of 3 or 4 people. It's not one person's attempt at all. It's absolutely a team effort to get the wire into the into the ampulla. You get into the CBD. Beyond that, next thing will start. How to cut, how much to cut, because we do not know how much of muscle is there around the diverticulum, particularly with outside and diverticulum and other things. Then we don't know. We have to be very, very careful. Just go bring it up only in the center.
Is it so that patient with the diverticulum, the ERCP complication rates are more?
The only way I can say is that it is difficult. It is little difficult, but it is slightly more even if there is a large stone, because it is not like it will be little floppy in the bottom. You will be able to pull it out much more easier. And often you see this only in 70, 80-year-old tatas and parties who will have these diverticulums and things, not in very young people. So it is sometimes it's easy to draw out big stones also.
Okay. Yeah. So here the ERCP they failed here. Next.
Due to the failed ERCP, she was discharged at request. She visited yet another hospital where she was reviewed with a contrast enhanced CT abdomen. and was advised open surgery.
Why open surgery?
Since the CECT abdomen did not reveal any calculus in the CBD, they had opted for an open cholecystectomy at that point, sir. Due to multiple trials of, due to the earlier trial of ERCP, they had opted for an open cholecystectomy.
It's strange, yeah. What does the CT show?
The CT showed a distended gallbladder with multiple calculi, which was picked up in USG correlation, central IHBR and EHBR dilatation, with a common bile duct size of 4.5 mm. It also picked up the periampullary duodenal diverticulum.
So effectively this patient, where one center, they went to another center where they did a CT and then, I don't know whether they had a plan to explore the CBD, I don't know, but they suggested open surgery. Yeah. Then what happened?
She presented to our OPD. She was admitted on the 28th of February. She was advised...
We are the third party.
She was advised elective ERCP and laparoscopic cholecystectomy in the same sitting.
You agree with this thing of elective ERCP lap chole?
I think we have way back.
Periampullary diverticulum, it's a difficult ampulla. The indication for the ERCP itself was not very clear. When there was the LFTs were normal, the symptoms were not suggestive. MRCP has suggested this one, but again the question of whether the diverticulum was superimposing as a stone. The CT has not shown a stone in this. There is hardly any dilatation. So mild, 4.5 millimeters. 4.5 millimeters. Again, as Dr. Ubal had suggested, the best way would be to, having done an EUS, make things clear. If there is a stone based on EUS, then yes, there's an indication for ERCP. If there's no stone, I think directly, again, if surgery is indicated.
The issue here is the patient party is quite an educated party. They thought ERCP is mandatory. It's failed somewhere, not attempted elsewhere, so in other place. And they said that possibly they'll explore the bile duct or something, I do not know. So when they come to a third party, they'll expect us to do an ERCP.
LFT, sir? Did we repeat an LFT before we took a call?
Did we repeat LFT?
No, we did not.
I completely agree with your peer pressure that because of the expectation that this ERCP may be carried out. I think it is fully agreeable in the social setting context. But on a medical context, what Shesh is discussing is right. But I would also thought that there will be pressure by the family on us to go ahead with the ERCP.
Well, what would you do with the patient? Because I know what I do if the patient comes to me. What will you do? You are thinking my thing may be different. What patient came to me actually.
Yeah, if I am working with you, probably you will refer to me. That because
No, it's not probably.
Yeah, that is how you are confident about your endoscopist, basically.
Right.
But retrospectively thinking that we should have documented in this case and go ahead with the ERCP. So I would feel either as a repeat LFT or because the second CT didn't show any CBD stone.
So I think the LFT, repeat LFT could have been but if repeat LFT is normal, then no ERCP.
There are times we have seen some chock-a-block CVDs with stones and normal LFT. I won't go only by the LFTs alone. But my only thing is that, yes, I agree the CBD is only 4.5. But look, there is some mildly dilated hepatic radicals. I don't know what does that mean.
We often get the reports, we can't decide anything on this.
See, ultimately you are boiling to a point. The justification of a ERCP in this case. Right. This is going to be on and on and on. There is some social context, like there will be some peer pressure coming to the third party after so many things. You just want to prove yourself that you've got a fantastic ERCP like Bala, then you will do it all. But then there is all that is how I would probably judge. Okay, in our hands it is just easier means go and get the ERCP done. The same sitting, between that the ERCP and same sitting cholecystectomy, I think we have discussed once. It's a one-day procedure. Like. I think it is not uncommon for people to have a ERCP followed by a couple of hours later you can do a gallbladder.
See, day before yesterday, we had a gentleman, 60 plus, who had gallstones, bilirubin of 5 point something with direct hyperbilirubinemia. And we asked our, it's very simple actually, we'll ask our gastroenterologist to go ahead with the ERCP. But they will have a look, I said, not required. Not required. So I went and did it's a gangrenous cholecystitis, that and other. See, actually, they do apply their mind. But when they ask us to do gallbladder, we don't apply our mind at all. Because, there's no need to apply as a matter of fact. But, hi, hello. Welcome. The surgical team is getting strong. Yeah. So you should get a background. This is a patient, 61, with some vague abdominal complaints, but all that there's some stones in the gallbladder. A left is normal, and there is some speck in the lower end of the bile duct, query calculus, and then with the perimeterian diverticulum, ERCP attempted, failed. The patient moved to another hospital where they did a CT, which is sort of normal, excluding gallstones. For some reason, they suggested open surgery. They didn't attempt ERCP or whatever. Now, patient was unhappy. They came to us, and this is where we are. She was planned for elective ERCP, lap cholecystectomy. In the same, we do it the same setting which me and Ubal have sort of started doing many years ago. Yes.
She underwent ERC, pre-cut papillotomy, sphincterotomy, CBD clearance, and laparoscopic cholecystectomy on the 1st
a word
of March.
about pre-cut, Pirama. What is this and why is it done?
So when we have a difficulty in entering the bile duct, in a normal conventional cannulation, we try to selectively cannulate either the pancreatic duct or the bile duct. Sometimes the guide wire doesn't go into the elective or the duct that which we want to cannulate. Sometimes it may get into the pancreatic duct but not into the bile duct. And that setting, when we are not able to get a wire across, other option is to put in a dye and see if we can opacify the duct and use your guide wire to get in. Sometimes even that may not happen. If that be so, then we can use a pre-cut in which we cut either from the top of the ampulla down to top of the ampullary fold down to the ampulla, or you start the cut from the ampullary orifice up till that duodenal fold, hoping in the direction of the bile duct. So usually it will be in the 11 to 12 o'clock direction. We try to place a cut with a needle knife where we are not guided by the guide wire in the bile duct. So we don't know. We have to cut it layer by layer, mucosa, then subsequently the submucosa, and possibly when we cut the muscle, it is kind of blind in a way. We are hoping that we are going in the right direction. So that is a small risk when you do a needle knife papillotomy. But once we get into the bile duct, then we get the guide wire across, we inject a dye and make sure what is happening inside.
That's a common thing, isn't it? See, here you say pre-cut papillotomy. Only the endoscopist is going to say whether how much of difficulty they had faced, how many attempts they have made, if they enter into the pancreatic duct, all that we don't know. They should have tried, and honestly, they couldn't have made it. So, no, their aim is to get into the right duct, the CBD. So, some way or other, they have to get in there. So, they should have gone ahead with the papillotomy, exposed the lower end, and then gone in. This is the usual procedure that's being followed.
You notice that the CPD is normal, since there's no stones and no calculus and good bile flow noted. Yes. No diverticulum reported. There was no comment on diverticulum and the endoscopy.
No, sir.
They won't have mentioned, right?
But when they did the first papilla, when they did the first ERCP, it says there is a diverticulum.
CT, MRI.
No, even CT show.
அந்த picture, முதல் ERCP பண்ணும்போது ERCP அது பெரிய திடீர்னு காணாம போச்சு நான் எப்படி போச்சு
It's not mentioned. Not mentioned. MRI says, CT says there is a
Okay. Probably they didn't mention it out.
following which she underwent the conventional 4-port laparoscopic cholecystectomy. The liver was normal, the gallbladder was thin-walled and well-distended, and the gallbladder had multiple cholesterol stones. The procedure was uneventful. On postoperative day 2, she developed complaints of bloating, loss of appetite, and nausea. Progressively, she developed diffuse abdominal pain with a serum amylase of 1057 and serum lipase of 1811. She was diagnosed as ERCP-induced pancreatitis. At this,
You have any criteria to call any cutoff?
Third day. Ubal, how can this be post-ERCP pancreatitis on the third day of the ERCP?
Was it a drop stone?
Day 1 முடிஞ்சிச்சு. If the patient had developed it on the day 1, then I would have agreed 24 hours later, within 24 hours. You call this on day 3, 72 hours later, somebody developing pancreatitis, it could be due to different reasons apart from ERCP.
Post-laparoscopy.
Third day when the post-ERCP pancreatitis diagnosed.
Day 2 வந்து bloating, no appetite, nausea.
Pain is outstanding feature.
They are not.
Post-ERCP pancreatitis pain is outstanding feature.
Okay.
But I've seen patients within 2 hours, 3 hours எல்லாம் இங்க முடிச்சிட்டு அங்க இந்த இடம் கிளம்பறதுக்கு முன்னாடியே வந்துரும் வலினா.
So it should be immediate or
I would have expected 24 hours.
The pain should be immediate and enzyme elevation should be documented. There will be immediate elevation of enzyme, but it should be thus 24 hours.
Okay. I'll tell you, in all cases of ERCP, there will be some biochemical pancreatitis almost.
Right.
Almost. We will go and hit the pancreatic duct here, that way, and there will be some biochemical pancreatitis. Right. You are meddling somewhere, you will have it. But you don't get clinical pancreatitis. But clinical pancreatitis, within 2 hours, 3 hours, the patient will start having the pain within 24 hours. The same night and evening, catch up to the patient.
But this is a different setting because the same day you are doing a gallbladder surgery. The patient must be on under some kind of painkiller, sedation, and I don't know what is the intensity of pain the patient will manifest. So that is a problem in doing two procedures on the same day.
Now, in our series of 100 plus cases now, we had only 3 patients with pancreatitis proven. One of them stayed for a week and 2 others stayed for 2-3 days. But others, they're just okay. I mean, we don't believe by and large that the patient is likely to develop pancreatitis because there are many we discharged in the same day and they had no issues actually. This patient, we wouldn't have done amylase lipase, actually we could have done on day. And as you said, there's no pain actually. Patient had the vague complaints, but then this criteria, you have a certain criteria to call it any amylase levels to call it ERCP-induced pancreatitis?
No standard 3 times upper limit of normal, no different for
There is always a biochemical pancreatitis. Every patient will have a biochemical pancreatitis.
Right.
But then, if there is an associated peak, only then I will truly call it as a pancreatitis. See, it is. But you can always call a pancreatitis just because there is a elevation of amylase and lipase. But if the patient has pain, only then I will start thinking about whether the patient has got pancreatitis.
You have any comment? Story till now, sir. Any comment or any observation? Yeah.
So, but you know that this is going to be a difficult ERCP once attempted, and there is an perioperative diverticulum. Do you do anything to prevent ERCP complication?
In this case, I just shown that ERCP hasn't performed. Unless otherwise the endoscopist who did the procedure is there, we don't know how many times they went into the PD, we didn't know whether they have attempted, they kept on nibbling at the ampulla. If they gone into the PD, maybe if they gone into the PD, then knowing that it's a difficult thing, you can always put a stent inside. You can always give them a rectal endomethacin just after the procedure to see if you can reduce it. If there's going to be discussion on how to prevent post-ERCP pancreatitis, we will be discussing this later. But then, unless the endoscopist is here, I won't be able to say in what ways I could have prevented the pancreatitis. Like many times what we try and do is we go once, twice, and sometimes we leave the wire in the pancreatic duct and then go into the CVD. That also these days, has been shown to cause pancreatitis.
Does rectal indomethacin still has a role?
Yes. There are only 2 or 3 things that, as on date today, available to say has got some impact on post-ERCP pancreatitis.
This patient had a high pre-op probability of post-ERCP pancreatitis because female, normal CVD, no indication for ERCP.
I don't even say SOD.
Periamply diverticular, pre-cut symptotomy. These are all risk factors for pancreatitis. We don't know how many times they handle the pancreatitis, the injected contrast.
If there is such a high risk factor, should we go ahead with lab chole at the same city for these patients?
No. Basically, we should look for pancreatitis. We do all the tests like rectal indomethacin, put a pancreatic stent. We expect that there may be pancreatitis. We inform the surgeon, maybe we can delay surgery for a day or two, the patient develops pancreatitis.
If there is a difficulty in cannulation, would you advise the surgeon to delay the procedure?
No, if you expect the pancreatitis,
not expected.
No.
You have a difficult cannulation, there is multiple things.
No.
Nothing.
Is there a role for operatory also?
By conclusion, usually it was all right, but two proven indications, two proven strategies. One is rectal NSAIDs,
indomethacin or diclofenac. Other thing, if we cannulate the pancreatic duct, to stent it. So these are the 2 proven. Along with that, IV hydration, particularly if they are on surgery. ESG guidelines, initially we used to characterize the patients as very high risk for pancreatitis or low risk. High risk people were the ones who were usually administered this rectal indomethacin and all that. But now ESG guidelines have come up in the last 3 years back or so, where at least they recommend a rectal indomethacin for everyone who is undergoing a pancreatitis. So the risk of a problem with the rectal indomethacin is much lower, and probably the benefit is much higher. So they don't even classify nowadays as to whether they are high risk or low risk.
Yeah. She was kept NBM, Rice tube was administered, and she was started on antiemetics. She gradually improved tolerated liquids and subsequently solid diet. She was discharged on post-operative day 8.
Is there any role on post-op day 3 for any intervention there? Some are always putting a PD stent at that point.
When you do the ERCP, possibly that's the time. When you go in and
once pancreatitis set in, converting. You see, I'm sure you would have seen the frank symptomatic pancreatitis post ERCP, and majority of them become alright in 2 to 3 days. Do you have experience of keeping them for those many days, and then do you have any criteria when to discharge?
And they eat without pain.
No, the thing is, mild, moderate, and severe, that pancreatitis classification by Peter Cotton, one of the criteria is the hospital stay.
Right.
The length of hospital stay becoming more than, I think, 7 days or something, it becomes severe. Huh?
That's retrospective, mainly for studies, isn't
Correct.
it?
Use the microphone.
Should we change the criteria for discharge in pancreatitis in these patients? Anything specific?
No, see, because my concern is when you endoscopy, when you do ERCP on a daily basis, and you see that you keep them overnight, right? You don't do outpatient ERCP.
Outpatient.
Then would you be looking for any pain or discomfort before you see them off, or patients? They get discharged on their own even without your knowledge.
Nowadays, without my knowledge, my PG. Someone sees.
The team looks after the patient. The ERCPs generally are done at level of month. Okay? They get discharged around 3 to 4 o'clock, 5 hours later. Okay. They are completely asymptomatic, well comfortable. But we do warn them, if you have any pain, anytime you come back. The rate at which a patient comes back to casualty in the middle of night with pain, hardly, we don't know, I can't give you numbers. From what I know is that our ERCP patients generally maybe 2 in a year may turn up, and they turn out to be mild pancreatitis. We never had, I think the technology has improved in spite of having very little accessories. Still, touch wood, we have not had to face a severe acute pancreatitis related to ERCP in the last few years. Because we have got the data about post ERCP complications. Every year we have to present, but in that we have not come across anything. And if the patient returns back in the night to the cash with pain, we admit them and keep them.
Keep them till they become.
Within 2 days, we will usually, maximum 48 hours. They are all mild interstitial. They all go away.
Now, this is the present situation with your experience, but ERCP is evolved over years. You must have seen.
How was it during your training time? Was it the same? Or was it pancreatitis more?
Depends on the volumes also.
Or by the time you were trained, people are experienced already.
It also contributes, and slowly I think the technique has evolved. Initially we used to use a lot of dye. That again was when contrast-induced cannulation. I think that was one of the main contributing factors to a pancreatitis. Then probably I think most of the centers moved to a guidewire cannulation where we don't go and inject a dye as much as possible. So I think technique has evolved, and with that I think the rates of complications have also come down.
She came back the very next day with complaints of abdomen distension, obstipation, nausea, and breathing difficulty since post-discharge the previous evening. She was tachypneic with a pulse rate of 110 beats per minute and an oxygen saturation of 91% on room air. She was admitted, blood cultures were sent, and started on broad-spectrum IV antibiotics along with non-invasive ventilation and other supportive measures. The blood investigation that day showed mild anemia with a hemoglobin of 9.6, a total count of 23,000, and liver function test conclusive of post-ERCP. At that time, we reinserted the Riles tube, started on parenteral nutrition.
Ilango, anything more you would have done?
Chest X-ray.
For?
Chest X-ray, any patches or anything?
Yes, yeah. My question was, she does not have fever. Why were blood cultures sent, and what was the need for broad spectrum antibiotics? The one more follow-up question was there any imaging done for the pancreatitis after she was admitted and diagnosed with just biochemical pancreatitis? Was there any imaging done?
During the first admission, when she underwent the ERCP and laparoscopic cholecystectomy, there was no imaging, sir. But right after admission, on post-operative day 9, we did image her. She underwent...
that is a day after...
On the day of admission itself.
Second admission.
Yeah. Second admission on the day.
No, you mean to say that you had to have a image proof before going in for... Yeah. What are you arriving at?
Whenever we have a patient with acute pancreatitis, I usually, at 96 hours, or 72 to 96 hours, we usually do an imaging to make sure that it is interstitial alone and there is no evolving necrosis. That would have given a clue, is what I felt.
No, when patient is becoming all right, is there a need for a CT? I mean, we always believe that we do a CT and to act on it. The patient is not becoming better. We know it's in ERCP pancreas. The patient is becoming better. You want to have a baseline.
What I would say is, if you audit this is within 24 hours admission, readmission.
Yes.
Right.
So that probably indicates the problem was previously existing.
Yeah.
So,
I mean, problem should be pre-existing.
Okay.
Because this should be a continuity of the previous story. It shouldn't be something new. Yeah, what does CT show?
The contrast-enhanced CT abdomen showed features representative of post-cholecystectomy, a bulky heterogeneous pancreatic head and uncinate process with surrounding fat stranding, which is suggestive of acute pancreatitis, a dilated stomach, edematous wall thickening of the first, second, and proximal third part of the duodenum. There was marked fat stranding with mild fluid in the right perirenal space, paracolic gutter, extending into the right iliac fossa. She also had bilateral mild pleural effusion with thin pericardial effusion.
do we still need antibiotics?
You think we don't?
I feel we don't.
Right. But that's
just
a
mild
very,
interstitial pancreatitis.
but that's still sort of controversial, but it's not wrong, and I feel because
Just a show of hands, how many people use antibiotics on a regular basis for acute pancreatitis?
this is not a
Right.
this is a
Multiple interventions, vague well,
this patient obviously, because even the surgeons and gastroenterologists feel that they are the reason for the pancreatitis. So you feel you tend to use antibiotics in this case.
And will that make a difference even though you have seen an interstitial pancreatitis?
It is not see, you feel psychologically you feel better. it is not
eminence.
It may not be scientific, but
radiologically it may be interstitial, but by organ wise it is more than just a mild pancreatitis. She is saturating at 90% on room air. I wouldn't be very comfortable with her.
In this case is that the patient stayed in the hospital for 8 days. Very likely they will get into trouble with infection. If anybody stays beyond 1 week in a hospital, the chances that they have contracted an infection is very, very high. So, on the second admission,
anyone would like to agree with Ilango and disagree with the rest? Anybody? Anyone? Regarding antibiotics. Anyway.
She's coming in sick. She's got significant leukocytic.
my next question, Dr. is that, see, this patient had a right-sided
pancreatitis and duodenal inflammation. I mean, is it anything like ERCP induced or multiple intervention induced pancreatitis will be onto the right side, or it can be anything?
it can be. I'm not very sure about that because ERCP doesn't produce only that focal inflammation. Doesn't like.
But will that give you some other suggestion that the duodenum has been tampered with or whatever? Because all through the story, her pancreatitis is right-sided only, head and uncinate and everything onto the right side. Because any comment on that, Tilango? How often do you see right-sided pancreatitis?
Quite rare.
When it comes to surgical intervention, right-side pancreatitis is a little dicey because the portal veins, SMV, etc. Especially if we do anything blind or anything minimal access, I am always scared of that.
That's the reason we don't know. See how far they were attempted before pre-cut sphincterotomy, whether the guide wire went into the pancreatic duct. Sometimes what will happen is the guide wire keep on turning into the genu. It will not go into the distal pancreatic duct. If they are manipulating the head region only, they may be a focal pancreatitis if they are handling it. But very sure, not very clear what is exactly happening at the time of.
The wire need not go into the main duct always. It can go into the genu.
any role for surgery in creating this pancreatitis?
A lab chole should not, because we are going.
Go near the pancreas.
No.
On the other
Sir, we can blame paracetamol.
Paracetamol tendency to affect the right side pancreas.
No, that I'm not sure of. But it also can produce pancreatitis. It can be drug-induced pancreatitis.
Okay. I think we'll keep that also in the list actually. Yeah.
This is a
Do you have any comment?
Post-ERCP pancreatitis still. The label post-ERCP in this patient, I'm not very convinced.
Hari is trying to pull out whether
We are trying to defend non-surgical pancreatitis.
I am trying to defend my endoscopist. This fellow goes and says that the patient will have anesthesia, so this still could be post-ERCP pancreatitis. நான் endoscopist pull பண்ணிட்டு இருக்கிறேன். போட்டு கொடுத்துட்டு இருக்காரு, சேம் செட் போட்டு இருக்காரு. The patient could be on painkillers, but still the third day diagnosis, I'm not clear about it. So some of these things are not clear, like why staying on only on the right side, and then you virtually you nearly discharge the patient home thinking that the patient is all right, and then she comes back and you get all these sort of pictures. Is that something recurrently triggering inflammation, like it happened on third day, maybe something happened on the 8th day post discharge that created the inflammation again? I don't know.
Yeah. Now, actually, all the while we were also wondering whether it's anything to do with ERCP, because the history and the subsequent sequence of events didn't really. But we have no other thing because surgery should not.
Lab chole should not cause pancreatitis. Drugs can cause, but other than that, I can't think of anything else. Because otherwise, they should have other routine metabolic causes, whatever. Slipped stone in.
Sir, you.
There was no stone at all. I think.
With a wide sphincterotomy, slipped stone should actually go
I
down.
just want to have one little idea, madam. Do you find post-CRCP pancreatitis in children? Is it more common than in adults?
Do you do ERCP in children? For what?
We are not doing it. It's same reason. CBD stones. CBD stones.
You have experience of doing. Because I've done a 3-year-old, 5-year-old alcohol very commonly, but have you done it?
He has done one on 2 years now. 2 years. 2 years now with stone lumbar.
How difficult is it? Or how easy is it?
I don't find any difficulty, but
Scope only. Scope matters.
Straight
The size
like
of the
this.
scope matters. Otherwise,
No. In this, in adult, the scope will be coming like this, and you will find it like a V, and you will see the ampulla. Here, hardly there is a small stomach. You know, you will straight away see the ampulla like this, and it's so, because it's a child's ampulla, and then there is no frequent passage of stones or not fibrotic and other things. Sometimes cannulation is easy, but sometimes it becomes extremely difficult when you can't get the position.
So for your question, documented sepsis or at least more than 30% necrosis. Otherwise, I've never used antibiotics in pancreatitis. It's almost never.
Organ failure?
No, that's quite.
See,
Creatinine of say 2 or 3 when it comes
No,
to
that's severe pancreatitis. Usually they will have
That's what I'm
associated
saying.
necrosis.
All
They
the
have
failure.
gone to that phase, yes.
I think that.
But in the early 8 days, no. Never used.
This is not a de novo pancreatitis. This is a patient with a long history, and instrumentation is done twice. Actually, I don't know whether Birma remembers when I was there in AIMS.
7 consecutive patients had gram-negative sepsis in the bile duct. I operated 2 patients, whole bile duct got gangrenous. After that only they found out some gram-negative organisms in the endoscope actually. That was the era, because I am always scared when you people, without gloves, the technician will be giving the guide wire. How can you put a guide wire into the bile duct? I'm always scared actually. When we, in the operation theatre, we can't do anything of that way. I'm always scared. And quite often the wires will be on the table or in somewhere and all that. See, now what I'm coming to is,
That's because the body takes care.
yeah. See, in this background, antibiotics, yeah.
Image of the contrast enhanced CT abdomen, following which we had to tackle many issues. She developed accelerated blood pressures. The cardiologist was involved. She was started on antihypertensives. The blood cultures which were sent earlier grew Escherichia coli. Antibiotics were escalated. There was persistent high Riles tube output. She was started on total parenteral nutrition. Due to the persistent high Riles tube output, she had dyselectrolytemia, and electrolyte imbalance correction was done.
Anything, Ilago? Yeah? Yeah, next.
Due to the persistent high Riles tube output, she underwent a contrast enhanced CT abdomen on the 14th of March, which was post-operative day 14, which showed an enlarged pancreas with multiple hypodense areas at the head and uncinate process, which was suggestive of necrosis. There was also a walled off fluid collection along the peripancreatic region through the right perinephric region, tracking down along the right paracolic gutter into the right iliac fossa. She also had mild free fluid in the pelvis. This is a representative image.
I think that statement we have to disagree, isn't it? It's still less than 2 weeks. Should not be walled off. It is acute necrotic collection. It's mainly for the PGs.
Go back. See, where is the walled off thing?
Second line.
Yeah, that is a CT report. No, I agree with that. See, I think radiologists should be aware also as to at what level and what time, I don't know, they were whether, because this is a report given by the radiologist, but that I think that's an interesting point.
Nirma, can I have the microphone?
No, sometimes we do see walls, not a well-formed wall. So the teaching is that usually we wait for 4 weeks. We call it as a usually it takes about 3 to 4 weeks for the wall to form. But on CT, sometimes even in the second week or towards the early third week, you do see some kind of walling off.
The idea is that acute.
I mean, if you find a wall, you find a wall.
The idea is that if you say acute necrotic collection, we still give it time for evolving. We feel that the walled off necrosis probably is quite complete for intervention.
I think that's an interesting point that we shall take it. Yeah.
And passing through slowly into the duodenum. She had heterogeneous walled-off collections in the right perinephric, anterior, posterior and pararenal spaces along with the superior mesenteric vessels tracking into the right iliac fossa.
Now here, because this patient is very high relative aspirate, sort of non-bilious, we expected the duodenum is obstructed.
Because the head edema, so there's a reason we did a oral contrast, and of course this is where we'll come in with a nasojejunal tube. Yeah.
This is a representative image. Due to the previous CT findings and line-related sepsis, it was decided that she would benefit from a nasojejunal tube placement. It was done on the 22nd of March.
Yeah, endoscopy. No, actually, frankly, I felt, I don't know whether Magnus will agree with me, that is not such a simple procedure. Like it is not successful all the time. I've seen gastroenterologists struggling to put why is it so? What is the struggle in putting an NJ? They do struggle. Ubal?
Basically, it is dilated stomach. It's very difficult to maneuver, go across the duodenum and put a wire, because there are two kind of nasojejunal feeding tubes. One is 10 French. Beyond that, we cannot go through the scope. So you have to put a wire, and over the wire we have to put thread the nasojejunal tube. Sometimes what will happen is it will keep on coiling in the stomach. So it is very difficult to direct that. That is the reason for putting up.
Goes along the greater curve, gets into the pylorus, gets into the duodenum.
Okay.
So if it is over the wire, you start pushing, you will only coil more in the stomach. That will draw the wire out of the duodenum and jejunum. The more you try to push, it will keep going into the greater curve. It will keep pushing into the greater curve. And the more and more you push, the wire from the jejunum will keep coming back. It's not easy, like you can't have something straight from the OG junction to the pylorus, then straight. It is not like that. It has to go only through this way.
Oftentimes I thought ERCP was easier, it's quicker than putting an NJ.
By the time you think that you have successfully placed, by the time you come back, you will see mostly the
stomach.
tip is in the stomach. Very difficult.
Ilango, you use NJ, you have any problems?
Yeah. This needs an NJ. There is no other way we can get around.
Okay.
The story gets interesting every time. Every slide is one thrilling move.
Yeah.
The
More
very
to
next-
come. Yeah.
The very next day, hemoglobin.
Why will there be hemoglobin drop in pancreatitis?
Hemolysis, sepsis, hemolysis.
Okay.
There was anemia with a hemoglobin of 6.7. She was transfused with 2 units of packed red cells. The blood cultures grew Candida albicans with elevated serum procalcitonin of 18.70 mcg per liter. She was started on injection fluconazole 400 mg. However, her general condition worsened. She was shifted to the intensive care unit in view of persistent tachycardia and desaturation. At this point, we involved the pulmonologist and the cardiologist. The infectious disease team was also involved, and they started her on injection micafungin 100 mg and injection teicoplanin 400 mg. After a window of about 24 hours, there was no improvement seen. So we took her up for a minimally invasive.
Yeah, Ilango. Ilango? But this is day 24 and in a worsening general condition, and we thought we should intervene.
Why not put a pigtail? It was very accessible collection on the right side.
Why wasn't a pigtail put in?
She was not very stable to be
That
transported.
can't be.
Pigtail is, I think, the problem is.
No, see, we rarely operate in acute pancreatitis. Rarely. I mean, we have patients repeat pigtails. This patient also will have a pigtail at some point of time. You know, but see, this pus was onto the sort of surface, and I thought I should make a nick. It's a small nick only I made actually, and the pus just came out. I don't know. I can't explain why that wasn't done, but we routinely do a percutaneous drainage.
So the decision was based on the changes in the skin. So that
Yeah.
made you change.
Yeah, it's sort of bulging out.
Approximately 100 ml of purulent material was drained and sent for culture and sensitivity. Necrotic tissue was excised and drains were placed to facilitate irrigation. The very next day, her general condition dramatically improved. She was weaned off of inotropic support and invasive ventilation. Progressively, the pus cultures grew Escherichia coli and Pseudomonas aeruginosa. The antibiotics were escalated to injection ceftazidime, avibactam, and injection aztreonam with reference to the antibiotic susceptibility report.
Anything else, Ilango, if you carry on?
On post-operative day 31, she developed hypotension and desaturation. We took a review from the pulmonologist, and they suggested she needs a CT chest due to irregular breath sounds on auscultation. The CT chest showed multiple diffuse scattered subpleural and centrilobular nodules seen in both the lungs, which was suggestive of infective etiology. She had a minimal left pneumothorax with a left pleural effusion and bilateral basal atelectasis. The CT abdomen showed diffuse fast stranding seen around the head of the pancreas and the duodenum, with a bulky heterogeneous pancreatic head and uncinate process was also identified. There was a thin hypodense collection seen in the perinephric space along the right pararenal space and right paracolic gutter. The drain tube and the nasojejunal tube were seen in situ. These are the representative images.
Abdomen is already tackled.
Yeah. Next.
Surgeon's job is done.
Yeah.
Why left pneumothorax?
That's what I want to know. Well, pneumothorax. Was the central line put on the left side or something? No, because actually when the patient is in the ICU, when we go on rounds, there'll be a screen. The patient is fully covered and 2-3 people will be doing something. I mean, that is without any consent or any concurrence, but we can't object. We see that quite often. One of the things we can think of is that actually. Ilango?
Yeah, that's possible, but there was no intervention documented. Huh?
No, sir.
Yeah, maybe we should have looked into, because when we see, the way we think is we see pneumothorax, we get the chest people to put a chest. We don't try to see, it'll be fault finding thing is to see why it happened. Actually, quite often the ICU people will keep quiet about it. They'll not say. They silently, because quite often one of the junior person will be doing it and something would have happened and they'll not say anything about it. And we can't ask them if somebody did this. Yes.
We involved the cardiothoracic surgeon to place in left ICD, and further escalation of antibiotics to injection phosphomycin, to injection minocycline and cotrimoxazole was done with reference with advice from the infectious disease team.
Here, do you choose the antibiotics or your ID people choose?
Now it's all ID people, sir.
It's mandatory. Same with you also. ID don't come in by now.
ID induced pulmonary.
And Hari, you have a comment here?
நீங்க எழுதுங்க நான் பார்க்குறோம்.
Problem is solved on the abdomen side.
Antibiotic. They, in inverted commas, they are looking at antibiotic resistance because we use. They all feel we use antibiotics recklessly. So they are policing the use of antibiotics by us. Rather than, we use and they come and check and tell you use this and that. We let them give permission for them to use. We simply sit and watch out of that.
But all the time I see that they use much higher antibiotics than we use. They're much more expensive than what we use.
Always, yeah.
In spite of the fact that they'll say that you recklessly use antibiotics. I'll be very scared they'll be combining 2-3 antibiotics, the costliest of the whole lot. And that will be going on for quite a while.
No, I see that you have added ceftriaxone and avibactam with aztreonam. They will do a test for that. That itself will come to around 20 or 22,000, something like that. It's a very expensive.
Yeah, Hari?
Their only weapon is antibiotics. So, unless they use the highest antibiotics, then they can't be called ID. That's the only problem.
That's interesting. Yes.
Going forward, on the 2nd of April, post-operative day 33, the hemoglobin was found to be low of 6.8 grams. 1 unit of packed red cells were transfused. She had also developed acute kidney injury with a blood urea of 216 milligrams per deciliter and a creatinine of 2.83 milligrams per deciliter. The nephrologist advice was taken, and they advised sustained low efficiency dialysis, which was done on consecutive days for about a week.
I'll ask one silly doubt. There are quite a few physicians here. This blood urea and creatinine, the PUR creatinine ratio is more than 60. Would you consider pre-renal stuff? That's what I would feel.
Yeah, but here we have a robust nephrology service, and as Hari says that antibiotics is the only weapon, then the nephrologist, this is the only weapon they have. And the throw of a hat, especially in a patient who's sick like this, they don't want to take chances. Yeah.
2 months.
Second month. No, not of necrosis. For the time of admission. Yeah. Yeah, yes. Okay. Both cholecystectomy won't have caused any of these. They cause a different set of problems. We can present a case, many cases like that.
Due to the low GCS, the neurologist's opinion was taken. They needed a CT brain, and to see the resolution of the pneumothorax, we needed a CT chest, and a CT abdomen was also combined.
No, because if you have a patient like this who goes CT, you run the machine down. Yeah.
The CT chest showed no residual pleural effusion and complete resolution of the pneumothorax. The CT brain showed no acute cerebral infarct or hemorrhage. And the CT abdomen showed the right flank drain in situ with an interval appearance of mild perihepatic fluid and pelvic ascites. The pancreatic head and uncinate process remained bulky with persistent stranding around the head of the pancreas, duodenum, right pararenal space, and right paracolic gutter. There was a thin hypodense collection at the head of the pancreas region, right perinephric space, right pararenal space, and right paracolic gutter, which was persistent. These are the representative images. She was hanging on about post-operative day 37. Repeat blood cultures done by the ICU team showed invasive fungal sepsis. She was started on injection amphotericin B by the infectious disease consultant, and all the other antibiotics were stopped. After successful spontaneous breathing trial, she was extubated and kept on BiPAP. There was peri-drain ooze and blood-stained drain output noted along with a significant drop in hemoglobin. So we had stopped injection Clexane and transfused her with 1 unit of packed red cells.
Ilango, this is something which we are always scared of. There is a drain very close to the portal vein, and when we see blood, I've seen patients suddenly blood gushing out, succumbing. we will not have any time. When blood comes from any of the drains in acute pancreatitis, we are doomed.
Scary.
Yeah, anything.
Repeat blood investigations the very next day showed hyperphosphatemia and hypocalcemia. The nephrologist review was taken and they advised to administer injection calcium acetate. Despite the multiple antibiotics, she had persistent low-grade fever and a repeat pan culture was sent which grew carbapenem-resistant Klebsiella pneumoniae with prevalent NDM mutation. The infectious disease team suggested that we restart her on injection ceftazidime avibactam, aztreonam, along with vancomycin. Further, her RISE tube showed blood-stained output on post-operative day 51, along with which there was significant hypotension and desaturation, which were dealt with inotropic and ventilatory supports by the ICU team. They suggested that we do a CT abdomen, which showed a residual hypodense collection measuring 10 cross 2 cross 14 centimeter with air pockets along the posterior perinephric space on the right side with caudal extension along right paracolic gutter into the right iliac fossa. The Foley's catheter was present in situ. And the stomach showed ruminal residues and hyperdensities, which are suggestive of blood clots.
Now here, actually, frankly, I mean, the physicians are not involved at all. The gastroenterologists are happily doing RCP, and what do you do? Because we only have to keep. They have no idea. There's a patient had an issue. I don't blame anyone, but I'm saying, you all work together.
You still want to go ahead and say that this is supposed to be
Point.
I don't think I will take the blame.
This is not.
Then what is it?
I don't know. Some ways.
Pancreatitis.
No. See, no, Ari, I'm not finding fault because we work together. I mean, see, we always expect that PG trainees also at least come and have an idea.
That's what right in the beginning I said. When we haven't got any proof, still the endoscopist comes and says what has happened. I will not accept, but the temporal profile doesn't fit into post-Yasin. That's the only problem.
Yeah.
On further investigation, coagulation profile was deranged with an INR of 2.10. She was given 4 units of fresh frozen plasma and 1 unit of packed red blood cells. Anticoagulants were withheld again, and she was weaned off of hypernasal cannula.
I'll also say one little thing. The patient is well to. First thing. Second thing is, got a son who was there all the while. He was never away. And the son comes and says, nephrologist says something, ID says something, the ICU people say something, you say something. Don't you all people talk to each other? Umpteen times you say. Rounds after rounds, every team comes and they say something. And which is contradictory to what the other team says. This is a major issue,
Yeah, I think communication is the key.
But how do you do? You have a combined meeting and a regular
Once you reach a certain level, the family starts getting agitated, or if you feel the communication is not happening between the family, with the family for the patient, with the doctors, you call all the doctors, have a family meeting. That's what regularly has been done.
The other thing we can do is consulting teams are not allowed to talk to the patient directly. ID or sometimes the critical care.
What the LMO says, that is mandatory. See, the admitting doctor is the primary responsible for the patient care. The rest of the doctors will speak to the primary doctor. They will not directly talk to the patient.
See, these people, in this fellow included, they are in communication with some doctor in Delhi or some doctor in US. They keep getting inputs. He keeps sending pictures of WhatsApp pictures of antibiotics and this and that, and everything they want to cross check. See, once the patient is not doing well and the money is increasing, they think that what you are doing is not right. And you are all individually what you are doing is not right. You are not sitting together and deciding what to do. That doesn't get
This happens only when there is an See, when you have a problem, you know, this is an iatrogenic problem. Let's assume, okay, finally I agree that this is iatrogenic. Okay, this is an iatrogenic problem.
Okay, this is where there should be an efficient communication between you and the family. Same time, don't put down, you know, you and I, you know, you're a surgeon, I'm a physician working together. No, there is no way you're trying to help me and I am trying to help you. Both of us together should make sure that, but what happens is that when 4 or 5 teams are there and they feel that the blame is going towards one particular team, in an anxiety to come out of the loop, they simply say, this is not our problem, this is just in front of the patient, just to wind themselves away from the problem. This is what is miscommunication. That's what the patient receives as us all not this thing. Particularly when such problems like this iatrogenic issues are there, I think we should work as a team to save each other, not to put one other into trouble.
Time and again he keeps asking, doctor, why did this happen? If you were in my position, what would you say?
See,
she came for a simple gallstone. Why is this happening?
Very difficult question to answer. I'll tell you, but at the same time, you can't put the blame on the physician that this is part of the complication. But we can only try to explain that such things can happen. But
Pre-procedure. When we say things, such things can happen, then we are accepting that a certain thing has happened. You know, a certain individual's, technical fault or whatever. You know, that's very difficult to hide. We try to hide that this is procedure related. We should say some other reason. I don't know, Ubal, whether you face that and whether you answer that. Because you do procedures, so many per day. When there is a problem, procedure related problem, say for instance, how do you?
Some of the problems we need to tell. Suppose like a colonoscopy, kind of difficult where the patients, you are almost going to lose the patient. So that kind of time it is very difficult to explain to the patient. So that is difficult. But invariably it is mandatory to tell the patient that what is the reason for that. If it is due to the procedure related, you have to tell. That is.
Yeah, there the problem comes that you have to support your colleague, the physician.
No, it's best to tell the truth and explain and leave it to the patient whatever he wants to decide. Not the truth means not the frank truth. You got to put the truth across, but not in a obvious way. Try to explain that these things do happen. You will have to take one at a time. We are trying to solve, but make them understand that we are doing everything in the best to see that we are bringing the patient out. That's the only way. But it is a difficult situation, I agree.
Since the previous CT abdomen showed an unresolvable residual hypodense collection, she was taken up for pancreatic necrosectomy on the 25th of April after optimization. The abdomen was opened through the previous incision. About approximately 20 cc of pus was drained, the necrotic tissue was removed, and the cavity was packed with roller gauze.
Now, I'll tell you why this has to be done. The son will ask, sir, you change the antibiotic, but still running temperature. Then you irrigate it, still running temperature. What next? Then I'll say the CT is showing. So how will it come out? Okay, we'll operate. You're sort of now into a difficult situation because the patient's party also keep monitoring the imaging and why things are not getting better.
She was extubated on post-operative day 2 of the necrosectomy and kept on high-flow nasal oxygen. The nasogastric aspiration increased, further causing dyselectrolytemia. On further probing, the nasojejunal tube kinking was identified with an X-ray abdomen. So she was restarted on total parenteral nutrition. On post-operative day 4 from the necrosectomy, she became hemodynamically unstable and was re-intubated along with dual inotropic support. We were asked to do a CT abdomen by the ICU team to rule out intra-abdominal collections. This is the abdomen X-ray that shows the kink in the nasojejunal tube. The CT abdomen showed residual hypodense collection measuring 6 cross 1.2 cross 6 centimeter with air pockets along the posterior perinephric surface on the right side with caudal extension along the right paracolic gutter into the right iliac fossa. The drainage Foley's catheters were also present in situ. These are the representative images. Further along postoperative day 60, she developed second and third finger gangrene. We sought advice from the vascular surgeon who advised to start her on injection Clexane. At this point, her coagulation profile was deranged with an INR of 3.38. So a decision was made to defer anticoagulants. Since we could not feed her via the nasojejunal tube, a trial of nasogastric feeding was done, which was unsuccessful, and we had to restart her on parenteral nutrition eventually. The perioperative cultures from the necrosectomy grew Elizabeth Kingia Anopheles, and antibiotics were escalated with advice from the ID team. Further, her hemoglobin dropped to 5.2 and she was transfused with 2 units of packed red cells. Another sudden drop in GCS was noted. The neurologist's advice was taken and a CT brain was done. This CT brain revealed a hemorrhage of size 1.1 cross 0.9 centimeter with surrounding edema in the right frontal lobe with subtle hypodensities which were suggestive of ischemic changes. There was no significant midline shift. The CT brain representative of the previous findings. The neurologist reviewed her. He suggested that the findings from the CT brain were chronic and they did not explain her current condition. However, they said that they explained guarded prognosis to the patient attenders. Due to several unsuccessful attempts at extubation, a tracheostomy was done on the 5th of May. Altered blood in the Ryle's tube with significant drop in hemoglobin was noted. So we did a bedside UGI which revealed linear esophageal ulcers. We restarted her on parenteral nutrition. She also developed grade 2 sacred blood source. Supportive management was done for that. The drainage catheters were upsized to 20 French Malicot drains and the necrotic material were removed. Regular irrigations were given. A polyurethane Frega catheter was placed and she was started on nasogastric feeding. Due to her persistent febrile spikes, we sent pan cultures which grew Elizabeth Kingia Anopheles, which was pan resistant at this point. The ID team advice was taken. She developed, as I told, she had developed bed sores, and this is the Frega catheter we used, which is made of polyurethane. At this point, this is the status of her laparotomy wound.
Lateral.
However, she pulled through, and about postoperative day 74 to 75, she was weaned off of oxygen support to room air. And since the oral feeds were not sufficient, nocturnal feeding from 12 AM to 4 AM were advised, which did not meet her protein requirements. Hence, she was supplemented with proteins with injection aminoven. The ENT specialist reviewed her with a video laryngoscopy, which showed vocal cord paresis, due to which she had swallowing difficulties, which were tackled with advice and therapy from the speech pathologist. Finally, at around postoperative day 126, she was discharged. She was off respiratory support, tolerated normal diet, ambulant, and was having normal bowel habits. She was reviewed by the ENT team periodically, and trial tracheostomy closure was done gradually, and decannulation was done successfully on the 8th of September as a day care procedure.
Bill? I'll come to it.
Most difficult.
Currently, she is on regular follow-up via the OPD. She has a residual asymptomatic hernia over the wound site, otherwise clinically NAD. Upon retrospective analysis, this is the trend of the febrile spikes she had due to the multiple pan-resistant microorganisms that she grew. Since it was very challenging for us to achieve her required carbohydrates and proteins, the trend of nutrition over the 4 months of stay are as follows. She lost about 15 kilos of weight, sir.
So the nutrition is very, very aggressive because this is a playground for them, to try all sorts of nutrition, the tube, the parenteral, the oral, all that, yeah.
Her required proteins were 1,533 kilocalories. Sorry, her required calories were 1,533 kilocalories and the proteins were 77 grams. Which we were able to attain in the last 2 months with May, during the month of May, since we started her on the protein supplementations with injection aminoven. We've come to the end of the presentation, sir.
Yeah. Now she's as normal as anyone can be, and then the bill was 64 lakhs. And they're rich enough to pay, and now the chap is a very special friend of ours. The reason why I want her to present is she has been through all. The dressing, the talking, the management. My physician associates are one of the best people on earth, and they're excellent, and any patient, any sick patient, they all remember them. And I think that's the reason why I thought she should present. And then this is all we've gone through. The antibiotics, the number of times intubation, the number of intervention, the nutrition, this, that, and other. Whether it is ERCP pancreatitis, I do not know, but it's pancreatitis. And, pancreatitis has often said that we do not know whether they're going to survive or not survive. Two is how long they're going to be in the ICU, we do not know. How much will it cost? That's what we say when, I'm sure even here, MDCCU, a lot of patients with pancreatitis will be there forever. Ilango, your comments.
Tough case, unfortunate events, and a very rough course. Glad she came out well. There's a beautiful movie quotation I think we can all remember. Andy, this is from Shawshank Redemption. Andy swam through a river of shit and came out clean on the other side.
I think, Radha, congratulations. You just got the patient back. Now, I was seeing the post-operative date 60, 70. 100 நாள் ஓடிடுவார் போல் இருக்கு எப்படி அதெல்லாம் நான் திடீர்னு வந்து பார்க்குறேன் 120 நாள் ஓடி இருக்கு நான் நடுவில் I just had a phone call, I had to go வந்து பார்த்தேன் 120 நாள். I don't know how the patient tolerated, but if there would have been financial constraints, I think you would have dropped the patient on the way. Somebody would have dropped the patient on the way. Because the family was affordable, you managed. And this the resistant organisms is indeed very, very horrible. The two carbopinum resistant organisms are the worst. They really give very bad outcomes, and to get out of those things is indeed a trouble.
My anesthetist says, if you don't know the name, then there is some trouble. The microbiologist also writes the name wrong, then you're in deep trouble.
I saw one name like King Elizabeth or King. எல்லாரும் அவளுக்காக ஒரு பேர் வச்சுக்கிறாங்க.
These days we see so many of them. Most certainly will be the royal, British royal. The sun is there all the time, 24/7 and on black t-shirt. Then I asked him one day, why man you don't wash your t-shirt? You're wearing the same thing. No sir, I have a number of black t-shirts. I thought because the way, and then his involvement was, he discussed with every specialist.
So, how did you finally did you answer the question or not? How did the ERCP happen? I mean, how did the pancreatitis? Did you manage it? No, I just want to know, how did you manage the family?
It's only one person speaking. See, some of these elite well-to-do people, they don't trouble you. It's all different social state, and sometime when things are going bad, different groups come at different periods of time, and that becomes very difficult. Only one person, one single person talking to us all the time, and is a more. You see, that chap knows my routine. What time I am in OT, today how many cases are there, what time I will come out, whether I seen or not seen. We were there in the notes, he'll be there, wherever he is. And he has taken his bath and all that in the patient's bathrooms and stuff. And that's an experience in itself. So I thought this is an interesting case to present as what ERCP, whether ERCP induced or not. This is a patient.
No, just goes to prove how unpredictable is the course of pancreatitis. Assuming many times we assume that we start off with an acute interstitial pancreatitis, but can go on, because from the beginning when you said that you discharged on day 8, முடிஞ்சிச்சு கதை ரொம்ப ஷார்ட்டாக முடிச்சா போல கதையை அப்படின்னு நினச்சா அதுக்கப்புறம் தான் கதையே ஆரம்பிச்சுது. So it is easy to assume that it's going to be acute interstitial nephritis, pancreatitis, but then it goes on, and the complications that the patient went through and the challenges you went through was, hats off to your team that you managed to bring the patient back.
Now, the other interesting thing, I just want to say something, but I forgot. But
Ilango,
you
brought up one.
The thing I wanted to say, in the first place, ERCP was not required. In this patient, it was not required, but this is what happened. Yeah, you're saying something.
Ilango said that did you do an imaging? Ilango asked, within 96 hours I'll do an imaging. Maybe if we had seen something done some imaging, like how he asked for.
What is that we would have changed?
I don't know. We might not have discharged the patient. That's the only thing I can think of.
Yeah.
Or would we have done something differently?
We see a lot of pancreatitis, as a matter of fact, and patient starts eating day 1, day 2, day 3, and he'll have definite idiomatic spine. We'll send them home. I mean, we know at least we know by the severity that which one are the likely ones who get into trouble later on. So we try to follow them, but otherwise, we don't keep them for long. Ubal, any comments? I think a big hand to. Thank you. You have something. My colleague, I told you can do something on ERCP induced pancreatitis induced complications. He said that is unfair to gastroenterologists. He said.
So post-op day 2 after ERCP, these are the findings. Can you tell us what's going on here? Dr. Ilango?
It's free air for that. Here under the diaphragm.
So there is pneumoperitoneum, yeah?
You got retroperitoneal layer also.
Yeah, retroperitoneal layer. And some subcutaneous emphysema also. Yeah, gas has spread following ERCP, challenging diagnosis. So what do we do for this case?
What are the symptoms?
No, he's totally asymptomatic. He had some mild abdominal distension, some skin bloating, and that's it.
Now, these patients, within minutes, they go into shock. They'll have severe abdominal distension, sweating, pain. I've seen quite a few in Delhi.
That side. No, the patient is subcutaneous emphysema, intrathecal gas, and all that.
This patient was stable, and apparently we don't do anything. We just wait. And in this case report also, nothing was done. He came out on his own.
I think first thing is any of these cases post procedure, we go back and see the video.
Okay.
Where something went wrong, something which we missed during the procedure, and when we come across this, first thing I think we should go and see something has gone. We have missed a perforation or something like that.
Same thing shown as subcutaneous emphysema, neoperitoneum, retroperitoneal layer. Another unique complication following ERCP. Can you tell us what's going on here? Tension pneumothorax complicating ERCP, and CT showed tension pneumothorax of the right side pushing the heart to the left side. So just was treated with the chest tube and nothing was done for the perforation. Post ERCP complication. Any idea what's happening here?
So the femoral canal collection trickled, and that was the place of IND.
Yeah, that's the place where they have done abscess drainage.
Incision drainage.
I've had one case where my junior operated for appendicitis post ERCP. Turned out to be just collection tracking retroperitoneally coming to the particular area. And what's happening here? Another complication of ERCP and stenting.
Stent is over the portal vein or inside the portal vein? Through.
Yeah, stent has gone into the portal vein. He had bleeding after the stent insertion. And apparently this patient was managed with just removal of the stent, and that closed it. So the theory is the stone in the CBD eroded into the portal vein, and the stent through the weak area has gone into the portal vein. Once the stent was removed, everything settled down.
Portal vein pressure is not so very high. It can.
So
some clot would have been there.
They had a laparoscope and a surgeon standing by when they removed the stent, and as nothing happened, they didn't do anything. I guess most of you might have seen. Can you guess what this is? It's a fragmented guide wire in the PD after ERCP. So what do we usually do?
Nothing.
Nothing. So most of them, these patients are asymptomatic, but a couple of cases are there where ripples have been done to tackle the complications following fractured guide wire removal. Another patient where the fractured guide wire has gone into the common femoral vein. Unusual migration. Post ERCP, patient not doing well. CT scan shows this finding. So any guesses? There was a biloma after ERCP. Not very common, but it
has gone into the chest.
That's a pleural effusion. Just a
if you see the density is the same.
Yes.
It's whatever material is here, it's there also.
There also. This one, this seems to be, I didn't know about this complication, but seems to be commonly reported at least. This is a hematoma which has been tackled angiographically, and in another condition they have opened up and found a large hepatic subcapsular hematoma also, again managed conservatively. There are many theories of why this is happening. This might be due to traction force exerted by the biliary duct extractor balloon, or due to guide wire puncture.
We published one case report like this of subcapsular hematoma after the guide wire, yeah. We published in SIMSEC one case of big subcapsular hematoma post ERCP.
Sir, post ERCP,
it's perforated the pancreatic tail and gone. The guide wire gone out.
No, this is most likely due to traction injuries. Excessive scope related direct traction or shear forces appear most likely causative of splenic injuries. So,
Basket.
Retained dormia basket, laparoscopically removed. What's happening here?
Choledocho duodenostomy. Or fistula, choledocho duodenal fistula.
Guide wire perforation of the periampullary diverticulum. Duodenal perforation. And tackle another case, tackled endoscopically with clips. This is a retroperitoneal hematoma showing a great Turner's sign. A very rare report where they had a cautery burn, ERCP cautery burning the liver, causing a myeloma in the liver. Sir, surgical question, sir.
No. Bile duct, the air in the bile duct and in the small bowel. Is that a stone getting into the small bowel?
Yes, sir.
To duodenum and blocking it. Gallstone ileus.
Gallstone ileus. So gallstone ileus, we know about cholecystoenteric fistulas.
What is the syndrome, gallstone ileus? Huh? No. Bowards. Okay.
So when you take out a large stone from the ERCP, from the CBD during ERCP, this can cause ileus stone.
You have to crush it so it will not block the intestine.
Very rare complication, but fatal. This gas in the port vein after ERCP. Another case where the gas has entered the brain also, though the fatal complication.
No. I asked you to do ERCP in this pancreatitis. It did all scary things here. And you upset everyone. Yeah, you have to conclude.
Thank you.
Thank you.
He knew it was tough handling as a surgeon. So I think it was a very difficult case which was extensively discussed, and handling such a case is actually very difficult in day-to-day basis. No? Explaining a complication, and first of all, most important is identifying the complication, I think. The first step, identify early, we can handle the complication better. Then accept the complication, talk to the patient's attender. And of course, I'm not accepting that this is post-ERCP pancreatitis, but in case such things happen, we have to. And I think another important point we have to take is when we do the procedure, explain the possible complications of the procedure before we do the procedure, so that they are probably tuned to it before we. Anyway, it was a nice case.
We have done over 10 CTs for that patient. Throw off a hat, we do CT, but we thought if we don't do CT, we do not know what's happening. I mean, you should hesitate to do.
Exactly. So I think it was good, and the next compilation of cases was excellent. It was very interesting. I think it was much more interesting than what would have been a post-ERCP pancreatitis lecture. So thank you very much. So we will meet next in 2 months. I don't know. I think we'll give a communication. Okay, we'll give a communication. We'll through the same group. I think whoever is not there in the group can be included in the group. It's getting heavier and heavier. Okay, thank you very much for all the attention. I think it should get more interactive next time. I think that side was not interacting much, that L. So next time expect more interactions, and it will be nice. Thank you. Most important part of the program, dinner.